Hello friends, today we are going to talk about pre-eclampsia, one of the very important topic in obstetrics and one of the frequently asked question. And what is meaning of the pre-eclampsia? In previous video we have discussed about the hypertensive disorder in pregnancy and the basic terminologies, and so today we will be talking mainly discuss about in detail in about pre-eclampsia. So what is pre-eclampsia? It is defined as a new onset hypertension and either proteinuria or other signs of end-organ dysfunction after 24 weeks of gestation in previously normotensive women. So what does preeclampsia basically mean? That it is new onset hypertension with proteinuria or other sign of end-organ dysfunction after 20 weeks of gestation. This is important, after 20 weeks of gestation in previously normotensive women, and this is known as preeclampsia. And preeclampsia is a progressive multi-system disorder, and the preeclampsia feature may be rarely appear before 20 weeks, as in the case of identiform mole or multiple pregnancy. Talking about diagnostic criteria, the absolute rise of blood pressure of at least 140 by 90 mm of Hg is commonly considered if the blood pressure of if the previous blood pressure is not known. This level is arbitrary and it is based on the observation that complications are likely to be more beyond this level, and a rise in systolic pressure of at least 30 mm of Hg and or a rise of diastolic blood pressure of at least 15 mm of Hg over the previously known blood pressure was also taken as pregnancy induced hypertension. So and how can we note the blood pressure measurement technique? The BP cuff length should be 1.5 times the upper arm circumference. The cuff with the bladder should encircle the 80% or more of the arm. The patient should be in upright position or sitting position or the left lateral position after 10 minutes or more rest period, and either case the occluded blood brachial artery should be kept at the level of heart. The PT edema, and next diagnostic criteria is after hypertension. One is edema. The demonstration of pitting edema over the ankle after 12-hour bed rest or excessive gain in weight of more than 4 pound, that is around 1.8 kilogram per week in latter month of pregnancy, may be the earliest evidence of preeclampsia. However, some amount of edema is common in normal pregnancy also. And proteinuria, the presence of total protein in 24 hours urine or of 0.3 gram or more, or urine protein creatinine ratio PC ratio more than 0.3, or dipstick more than 1 plus protein in at least 2 random clean catch urine samples tested 4 hours apart in the absence of urinary tract infection is considered as significant. And for revision, we can the dipstick the test for protein in urine by multiple reagent strip, that is dipstick, are as this follows. If it shows the trace, then it correspond to 0.1 gram per liter proteinuria, and 1 plus means 0.3 gram per liter, that is diagnostic criteria for preeclampsia, and 2 plus means 1 gram per liter, 3 means 3 gram per liter, 4 means 10 gram per liter. Now we will be talking about etipathogenesis of preeclampsia. The incidence of preeclampsia in hospital practice varies widely from 5 to 15%, and the incidence in primigravida is around 10%, and in multigravida it is 5%, and less in multigravida. And the etipathogenesis, the underlying basic pathology is of preeclampsia is endothelial dysfunction and intense vasospasm, and this is due to abnormal placentation, and this affects almost all blood vessels, particularly those of uterus, kidney, placental bed, and brain. The responsible agent for endothelial dysfunction and vasospasm still has not been known precisely, but there are various different underlying pathology that is going on. The one we have the for in the pathogenesis we have the trophoblast invasion and uterine vascular changes. So let's discuss this thing about in the from the picture. Here this is the picture showing the normal pregnancy, the placentation of the normal pregnancy, Normally there is invasion of endovascular trophoblast. There is normally invasion of endovascular trophoblast into the vessel of spiral arteriole of the uteroplacental bed in the first trimester. In the first trimester, the endovascular trophoblast invade up to the decidual segment, and in the second trimester, from 16 to 18 weeks, the another wave of trophoblast invades up to the myometrial segment, and this process replaces the endothelial lining and muscular arterial walls by fibrinoid formation. The spiral arterioles thereby become distended, tortuous, and the funnel shaped. This physiological change transfers the arteriole into the low resistant, low pressure, and high flow system. So endovascular trophoblast invading the spiral artery, and this is decidua. This is normal myometrium, and this endovascular trophoblast invade the spiral artery, and it reaches the myometrial segment in the latter due to the migration in the second trimester of pregnancy. And basically this is the normal phenomenon that should have take place. But in pre-eclampsia, the second wave of endovascular migration does not take place. As we can see, there is no migration. It has been stopped here. In the normal, there was migration that has reached the myometrial segment, but here it has halted in the middle. Here you can see in the decidua, and this is halted. There is failure of second wave of endovascular migration, endovascular trophoblastic migration, and there is reduction in the blood supply to the fetoplacental unit. So this is the basic pathology of the preeclampsia. Through this flowchart, we will be talking about etiology of the preeclampsia. We will try to understand it in a simple way as possible. And so first of all, we will talk about what happens in the normal. So in the normal pregnancy, firstly, the angiotensin 2, a part of alpha 2 globulin, is destroyed by angiotensinidase, which is liberated from placenta, and the vascular system becomes refractory selectively to the pressure agent, the angiotensin 2, and this is mostly due to vascular synthesis of prostaglandin I2 and the nitric oxide, which has the vasodilator effect. The interaction between two systems stabilize the blood pressure in the normal pregnancy. The vascular endothelial growth factor, or mitogenic glycoprotein, increases the vascular endothelial growth factor. This increased vascular endothelial growth factor restores the uteroplacental blood flow to the normal level, and that should have been take place in normal. This is in the normal. There is vasodilation, no platelet aggression, and there is increased uteroplacental blood flow, and this should have take place in the normal thing. And what happens in preeclampsia? This is about preeclampsia. There is imbalance of different component of the prostaglandin. There is relative or absolute deficiency of vasodilator prostaglandin I2 from the vascular endothelium, and increased synthesis of thromboxane A2. Thromboxane A2 is increased in the preeclampsia, and the prostaglandin I2 is decreased. The thromboxane A2 is potent vasoconstrictor in the platelet. There is increased vascular sensitivity to the pressure agent and angiotensin 2. And the nitric acid, this nitric acid is normally synthesized in vascular endothelium and syncytotrophoblast from L-arginine. It significantly relax vascular sulmothal, inhibit platelet aggregation, and prevent intravenous thrombosis. However, what happens in the preeclampsia, there is deficiency of nitric oxide, and due to deficiency of nitric oxide, it contributes to development of hypertension. And the endothelin 1 is synthesized by endothelial cell, and it is a potent vasoconstrictor. Endothelin 1 also contributes to the case of hypertension. And inflammatory mediators like cytokines, tumor necrosis factor, interleukin 6, and others derived from activated leukocyte cause endothelial injury. And abnormal lipid metabolism result in more oxidative stress, lipid peroxidases, reactive oxygen species, and the superoxide anion radicals cause endothelial injury and dysfunction. and the abnormal and the vascular due to poor cytotrophoblastic invasion in spiral artery. There is chronic hypoxia to the placenta. The state of chronic hypoxia causes the endoplasmic reticulum to activate apoptotic pathway, increasing oxidative stress and release of angiotensin to endoglin, FLT1, and the uric acid, and there is increased systemic inflammatory response to cause the endothelial damage. Here the placental growth factor is an angiogenic protein secreted by syncytin cytotrophoblast of the placenta. PIGF promote placental angiogenesis. Soluble FMS like tyrosine kinase SFLT1 is a circulating anti-angiogenic protein. It adds to the receptor site of PIGF and with this mechanism SFLT1 induces the endothelial dysfunction and prevents placental angiogenesis. The low PIGF and the high serum level of SFLT1 predicts onset of endothelial dysfunction. The imbalance of angiogenic and antiogenic protein in the placental vascular bed. There is overproduction of two anti-angiogenic factor from the trophoblastic tissue. These two anti-angiogenic factors are, like as I have said, soluble FMS like tyrosine kinase 1 SFLT1 and the soluble endoglin. This SFLT1 binds to BEGF and the placental growth factor PIGF causes endothelial dysfunction, and various other mutation in the factor 5 leading also increases the risk. So hence preeclampsia is characterized by endothelial dysfunction and the vasospasm. All these mechanisms lead to vasospasm and endothelial dysfunction, and endothelial dysfunction is due to the oxidative stress and the inflammatory mediator, as we have said and discussed in this chart. This vasospasm releases the result from the imbalance of the vasodilator prostaglandin I2, nitric oxide, and vasoconstrictor like angiotensin 2, thromboxane A2, endothelin 1, and there is imbalance between angiogenic and anti-angiogenic factors. That's what the basic pathology, and there is the pathology of hypertension, and the cause for edema is due to the cause of excessive accumulation of fluid in the extracellular space is not clear, but the probable explanation is that due to increased oxidative stress there is endothelial injury, and there will be, due to that, there is the increased capillary permeability, and on this basis the leaky capillaries and the decreased blood osmotic pressure are the probable explanation for edema. And the proteinuria, the probable chain of event is as follows: the spasm of afferent glomerular arterioles. There is anoxic changes to endothelium of the glomerular tuft, and that leads to glomerular endotheliosis and increased capillary permeability, and there is increased leakage of protein, and also tubular reabsorption is simultaneous depressed, and so that causes proteinuria. That is the mechanism. And due to the vasospasm and the endothelial dysfunction in the fetus, it results in various complications like fetal growth retardation, oligohydramnios, and placental abruption, and that finally lead to preterm delivery or intrauterine fetal death. And in maternals, it causes various other syndrome like vasoconstriction. Increased vasoconstriction causes hypertension. There decreased organ transfusion perfusion causes uteroplacental. There is intrauterine growth restriction. Decreased kidney it causes glomerular endothelium and oliguria. In liver, it causes ischemia and HELLP syndrome. In brain, seizure and PRES syndrome. There is posterior reversible encephalopathy syndrome. There is, due to increased endothelial dysfunction, there is capillary leak that lead to ascites, edema, proteinuria, pleural effusion, pulmonary edema, and due to activation of coagulation system, they result in thrombocytopenia, DIC, and HELP, and hemoconcentration and HELP. So that was the mechanism of the etipathogenesis of preeclampsia. We have all discussed it: trophoblast invasion and uterine vascular changes, normal pregnancy, what happens, we have discussed already, and preeclampsia due to various, these all factors we have already discussed it in the given picture. We explained the mechanism of edema and proteinuria, and that was all. There are various pathology for the specific organ dysfunction. The preeclampsia affect various different organ, and we will discuss it in very short. In utero placental bed, as we have already discussed, there is increased evidence of premature aging of the placenta. The areas of occasional acute red infarct and white infarct are visible. In villi, the syncytial degeneration, increased syncytial nerve, marked proliferation of cytotrophoblast, thickening of basement membrane, and proliferative indentaritis are evident. And also in preeclampsia, the normal endovascular invasion of the cytotrophoblast into the spiral artery fails to occur beyond the decidual myometrial junction. As a result, the musculoelastic media in the myometrial segment remain unresponsive to the vasoconstrictor stimuli, resulting in the decreased blood flow, and there is acute atherosclerosis of the spiral arteries with the obliteration of lumen. And the intravenous circulation, the blood flow is impaired into the exchange to about 1/3, and and the kidney, there is changes are conspicuous in the glomerulus, which become enlarged, glomerular endotheliosis, and there are various different pathological changes, and that result in decreased renal blood flow, and glomerular filtration rate is decreased. There is also impaired tubular reabsorption and secretory function, and in blood vessel there is intense vasospasm. The circulation is vasorum is impaired, leading to damage in vascular valve. And the liver, the periportal hemorrhagic necrosis occurs. There may be subcapsular hematoma in severe cases. There is right upper quadrant pain is due to stretching of Gleason capsule in the liver. And we have something known as HELP syndrome, and HELP syndrome we will discuss in some next video. In brain, there are various different pathologies like cerebral edema, capillary thrombosis, infarction, and parenchymal hemorrhages, intraventricular hemorrhage, fibrinoid necrosis, and all. And the clinical manifestation are of the headache, scotoma, blindness, and convulsion are due to posterior reversible encephalopathy syndrome. And in this syndrome, the posterior occipital and posterior parietal lobe, the reversible encephalopathy syndrome is a transient neuroradiological entity characterized by feature of hypertension, generalized seizure, altered mental status, and the headache and the vision changes. And the hallmark of diagnosis is bilateral symmetrical vasogenic edema in the occipital and the posterior parietal lobe. This is a picture showing PRES, the multi-lobe cerebral. It shows this MRI shows the multi-lobe cerebral, occipital, and parietal lobe abnormalities, and the posterior reversible encephalopathy syndrome in women with eclampsia and coma. There are some pathological changes in heart, the focal necrosis and hemorrhage in myocardium, subendothelial hemorrhage. These all can happen. And due to vasospasm, there is disturbance in the coronary circulation, and that might cause a disturbance in blood flow. And in lungs, there is evidence of edema or hemorrhagic bronchopneumonia or acute respiratory distress syndrome. And in other gland like adrenal gland show hemorrhage, necrosis, stomach show the hemorrhagic, show the feature of hemorrhagic gastritis, and the water and electrolyte balance are disturbed. There is intravascular volume contraction and extravascular volume accumulation. So there is hemoconcentration and rise in hematocrit value. The hematological changes, the blood volume, the extent of increase in blood volume in normal pregnancy is not present in severe pre-eclampsia. Thrombocytopenia is very common in hematological changes. Thrombocytopenia is a common hematological change. Antithrombin 3 activity is low. PTT, and the level of fibrinogen should be done. And if the platelet count is less than 1 lakh per mm³, and there is hemoconcentration with the increased hematocrit level, and there is evidence of erythrocyte destruction due to resultant hemoglobinemia and hemoglobinuria. There is evidence of disseminated intravascular coagulation as affecting widespread organ of the body, and this is due to this process is initiated by the release of thromboplastin into the circulation. There is reduction of the platelet, fibrinogen, antithrombin 3, and plasminogen level in the blood, and that the microangiopathic hemolytic anemia is the hallmark of HELP syndrome. And the hormones, the estrogen and progesterone level are lowered, and so that is not so important. And the biochemical values are the serum level of urea and non-protein fibrinogen are normal. In severe preeclampsia, both urea and urea and non-protein nitrogen are elevated. blood uric level is raised beyond the normal level of 4 milligram per deciliter. So we are going to talk about clinical types of preeclampsia or gestational hypertension. One is where preeclampsia or gestational hypertension with severe feature, and it contains one or following feature, various different feature, the severe blood pressure elevation. The systolic blood pressure is more than or equal to 160 mmHg, with or the diastolic blood pressure is more than 110 by 110 mmHg on 2 occasions 4 hours apart while patient is on bed rest. There is a central nervous system, a symptom of central nervous system dysfunction. The cerebral or visual disturbance such as photopsia, blurred vision, scotomata, cortical blindness, and the retinal vasospasm are there. There is severe headache or headache that persists and progresses despite analgesia. There is altered mental status and stroke. And hepatic abnormality, severe persistent right upper quadrant pain or epigastric pain unresponsive to medication. Serum transaminase is more than or equal to 2 times upper limit of normal range. There is thrombocytopenia. There is platelet count is less than 1 lakh platelet per microliter. The renal abnormality, the progressive renal insufficiency such as serum creatinine more than 1.1 milligram per deciliter is there, or doubling of the serum creatinine concentration in the absence of other renal disease. The pulmonary edema due to leaky capillaries and low oncotic pressure. And there can be preeclampsia without severe feature. These include cases of sustained blood pressure more than 140 by 90 mmHg, less than 160, or diastolic less than 110 mmHg without significant proteinuria and any other end-organ dysfunction. The clinical feature, preeclampsia frequently occurs in primary gravida. In 70% of the cases, the clinical feature appear usually after 20th week. The finding manifest either as maternal syndrome or fetal syndrome. The onset is insidious and the syndrome turns slow course. On rare occasion, however, the onset becomes acute also. And the symptoms of the preeclampsia is principally it is known as syndrome of sign, and when the symptom appear, it is usually very late. The mild symptoms are slight swelling over the ankle, which is persist on rising from the bed in the morning, or tightness of the ring or in the finger is an early manifestation of the edema due to preeclampsia. Gradually, the swelling may extend to the face, abdominal wall or vulva, or even the whole body. And the alarming symptom is the severe feature are the following are the ominous symptom which may be evident either singly or in combination. These are usually associated with acute onset of the syndrome. One is headache, either located over occipital or frontal region, the disturbed sleep, the diminished urinary output less than 400 ml in 24 hours. This is very ominous. Epigastric pain, the acute pain in the epigastric region associated with vomiting. At times, the coffee color is due to hemorrhagic gastritis, and the pain in right upper quadrant hypochondriac is due to subcapsular liver hematoma formation. And the eye symptom, there is maybe blurring, scotomata, and dimness of the vision, or at times the complete blindness can occur sometimes. And the vision is usually regained within 4 to 6 weeks following delivery. The eye symptom are due to the spasm of retinal vessel, due to retinal infarction, occipital lobe damage, vasogenic edema due to vasogenic edema, or retinal detachment. The reattachment of the retina occurs following the subsidence of edema and the normalization of blood pressure after delivery. The symptoms of the CNS dysfunction are, as we have already discussed, the headache and various other symptoms. Abnormal weight gain. Talking about the sign, there is abnormal weight gain within a short period of time, probably appeared even before the visible edema, and rapid gain in weight of more than 4 pound or 1.8 kg in a week in latter month of pregnancy is very significant. There is rise in blood pressure. The rise in blood pressure is usually insidious but may be abrupt also. The diastolic blood pressure usually tend to be rise first, followed by the systolic pressure. The visible edema over the ankle on rising from the bed in the morning is pathological. The edema may spread to other part of the body in uncared cases, and sudden and generalized edema may indicate imminent eclampsia. Pulmonary edema due to leaky capillaries and low oncotic pressure. There can be pulmonary edema, And on abdominal examination, that may reveal the evidence of chronic placental insufficiency such as scanty liquor or growth restriction of the fetus, and the brisk patellar reflex or clonus might be there, and the lab or abnormalities are due to hepatic, renal or hematological system dysfunction. Thus the manifestation of preeclampsia usually appear in the disorder. The rapid, first of all, there is rapid weight gain, then there is visible edema, hypertension, and finally there is proteinuria. And this is the sequence of the appearance of symptom in the preeclampsia. And the presence of thrombocytopenia and the oliguria, hepatic elevated liver enzyme dysfunction, pulmonary edema, and the cerebral and visual symptoms suggest that preeclampsia is a multi-system disorder. Now talking about complication of preeclampsia, the complications are more likely to occur if the patient is left untreated, and the complication can be either immediate or remote. And the immediate complication include maternal and fetal. The immediate, in the maternal complication, we have the complication might arise during pregnancy, during labor, or during puerperium. And during pregnancy, there can be eclampsia in 2% of the cases, more in the acute than in subacute cases. And there can be placental abruptio placenta, oliguria, anuria, retinal detachment, dimness of vision, and even the blindness, ophthalmic symptom. And the preterm labor, there can be preterm labor, HELP syndrome, and the cerebral hemorrhage, acute respiratory distress syndrome, ARDS, and the disseminated intravascular coagulation. Okay, I think video has become too long, so we'll discuss about the complication of preeclampsia in next video. Till then, keep waiting, keep revising and studying. Thank you.